greet you all today, our esteemed viewers who always tune in to this show, the community show that is convened by Center for Constitutional Governance and Civic Space TV. I am your host, Martin. Today we are talking about accessibility of health services by people living with disabilities. Now, the International Convention on Rights of People Living with Disabilities has mandated and in effect prescribed that persons living with disabilities all have equal rights to access health facilities. But first we shall define who a person living with a disability is. I don't know if later in the conversation our colleague will also further add on. But essentially, living with disability is when someone has these kind of attributes about themselves that make them not fully enjoy the rights like everybody else would. That is in simple terms. This could be from a physical disability or a disability that is not physical. And so the International Convention, the Convention on the Rights of Persons Living with Disabilities specifically provides for equality, and this equality is also provided for in the International Covenant on Civil and Political Rights, the International Convention on Economic, Social, and Cultural Rights, among others. But for purposes of our discussion today, we shall talk about specifically health. And what does the Convention on the Rights of Persons with Disability talk about health before we even go into the nitty-gritties with our discussants? It says that said parties recognize that persons with disabilities have the right to enjoyment of the highest standards of right without discrimination on the basis of disability. Parties shall take all appropriate measures to ensure access for persons with disabilities to health services that are gender sensitive, including health-related rehabilitation. In particular, states shall provide persons with disability with the same range and standard of free or affordable health care and programs as provided to others, including in the area of sexual and reproductive health and population-based health programs. And also, states shall provide health services needed by persons with disabilities, especially because of their disabilities, including early identification and intervention as appropriate, and services designed to minimize and prevent further disabilities, including among children and older persons. It also emphasizes access to health services in far-to-reach areas, including rural areas, and enjoins health professionals to provide health services on the basis of equality, taking into consideration, of course, the disabilities of others. Now, we have heard what the convention says. The Ugandan law also, we have an act on persons living with disability. It is couched in the same language. It provides for non-discrimination, provides for access to health of persons living with disabilities. This is also enjoined and guaranteed by our constitution, which provides for non-discrimination on any ground, including grounds of disability, among others, and it also guarantees the right to health. Now, to help us further understand how much this mandate of accessibility has been fast-tracked by the government in Uganda, I'm joined by a doctor who works with the Mulago, that is a national referral hospital in Uganda. She'll help us better understand how we have been in position as a country to further provide and further enable access to health services of persons living with disability. And I must put a disclaimer, she does not speak for government. We're also joined by Sabiti, who is a person living with a disability, who will also help us give his context. And I'll ask each one of them to introduce themselves and we shall proceed. We're also joined by Myleen, who is a person living with disability, and she will also help us give a context. Yes, I'll begin with you, Prima, Ivan, and then Myleen.
Thank you so much. Once again, my name is Niwampeire Maria Prima. I am a medical doctor at Mulago National Referral Hospital. I also volunteer with the patient-centered care movement, and I'm very passionate about community health. I'm very delighted to be here to join in the discussion. Thank you.
I am Kyomuhendo Myleen, a person living with disability because of an accident. I acquired a spinal injury, so I mobilized using a wheelchair, and I'm happy to be part of this panel to help spread the right information and maybe encourage someone out there to demand for their right. Thank you.
I want to begin with you, Prima. How do you rate, or in your view as a health worker, how do you rate our steps, our commitment to ensuring accessibility, and mainly to people living with disabilities in Uganda today?
Thank you so much. My rating, if it was on a scale of 1 to 10, I think I would give us 5. Reason being that we are all facing challenges in the health system to start with. However, the people living with disabilities have extra challenges, and well, much as we've tried to address some of these challenges, I feel like sometimes they are forgotten. I'm going to give an example of starting from the infrastructures. When we go down to our health center, 4's health center, 3's, we look at the infrastructure and the way these facilities are constructed, and you find that some of these facilities do not have a ramp access infrastructure. Those walkways where people are able to move with wheelchairs. Some of them don't. Ideally, such structures are supposed to be demolished, but we tend to forget them in the designing of these buildings and everything else. Walking into the OPD room, there are stairs and there is no access for such people. I was sharing with a colleague recently, and he was telling me, oh, I met a patient in the hospital and they were asking me where they can find this clinic. So I directed them. But then later on, when this colleague looked at where they had directed them, there were stairs. So he had to stop what he was doing, where he was going, to first help this person with a wheelchair access the consultation room. Because the way to the consultation room was just stairs and they had not put the ramp access area. So that and so many other challenges. The other challenge could be we also face this challenge as healthcare workers. So you find that both we and the people living with disabilities are in a dilemma. I'll give an example of someone who cannot talk and maybe they're using sign languages. How many healthcare workers out there are able to interpret sign language? Not so many of us. And yet a lot of our treatment that we give involves interacting with the patient. They tell you how they feel, how they are, where the pain is. So you find that if you are unable to take the correct history of this illness, it's going to be a challenge for you to come to a diagnosis, hence the right medication. So most times you find that we are using maybe the caretaker who has lived with this patient for so long to help them maybe interpret, to help us interpret. But you find that maybe there are things that the patient could have wanted to tell you and they don't want the caretaker to know. So you find that that becomes a challenge, the issue of confidentiality. Much as we have some specialized centers in Uganda, which is what brings us to the 5 that I gave. There are not so many and they don't cater for so many of them. Yeah, I'll give an example of POSU. It's usually for people with bone disorders and all that. However, these other, if they have any, if these people with bone issues and maybe let me say a broken limb need other health facilities, like maybe they are hypertensive or they have diabetes, yeah, they don't go to hospital, they still come to us, the general hospitals, which still takes us to the problem of healthcare system in people living with disabilities. So on the scale of 10, I think I would score us 5. Yes, thank you.
Thank you. Thank you very much. And to you, Myleen, how would you rate Uganda's commitment to Article 25 of the CRPD, but I mean mainly that deals with accessibility? How does Uganda score in ensuring accessibility to healthcare of persons living with disability?
Thank you so much. Once again, good morning. And thank you for everyone that is participating in this important talk. I'll rate us at 3. 1, the reasons being 1, healthcare includes rehabilitation. And rehabilitation is a whole package. For example, if I would give an example of my case, I wasn't born with a disability, I acquired one. And by the time I got the injury, there was no spinal unit. I was in the general ward for people with broken arms, broken legs. And the challenge there, I didn't have care that I needed. So I was at a risk. I even got infections in the hospital. You imagine, in a hospital and you get another infection. So that is to show you that there was no proper medical care. And I was at a risk even when I was in a medical facility, a government facility, because I was in Mulago Ward 2. So as an affected person over the years, I joined an organization and we lobbied for a spinal unit. We were given an empty room near Tasso. We lobbied for beds and the mattresses, and a Good Samaritan gave us. So we equipped the room. And as I speak, I'm happy to report we have a spinal unit with its own theater there. The challenge is, it is small. At the rate of accidents now, a patient takes only 2 weeks and we send them home. Why? They don't have the newcomers don't have where to sleep. Mulago being a national referral hospital, most cases are referred to Mulago for those who cannot afford the private treatment. So we have a challenge that even if someone has undergone surgery, they go home after 2 weeks. They have not recovered, they're not rehabilitated, they're not cancelled. And the worst of it all, they're not given a wheelchair, which is not a luxury. Government had promised us, but as I speak now, the cheapest is 150, the one offered by Mulago. But it is not the right type for us when you have a spinal injury. You're at risk of getting more disabilities after the injury because it is not the right type for us. And even when it's offered, it is not foldable. So it limits you. When you have it, you have to stay home or have your own car, which needs a van, not even a small car. So it is more disabling even when they give it to you if you can afford that 150. So that is one of the challenges why I rate us at 3. 2, most referral regions do not have this care for people with spinal injuries. It's only Lacho Hospital that is very good. Actually, Lacho is better than Mulago in the caring for people with spinal injuries. And that is because it has a mission background and is still supported in that same way. Lacho has a follow-up of their patients. Even when you're home, the doctors keep count and follow up to see how you're doing. Even when they discharge you, when you have a pressure sore, there's that care. So people in Lacho in Gulu are doing well. But here in Kampala, you are on your own. Even when you're at the spinal unit, if you do not have money, you not get the proper care you want. I was there for a second surgery to remove the metal plates that were put in my back to correct my spine. I fell down and they dislocated themselves. So I had the option to remove them because my back had stabilized a bit. While I was there, a nurse, I know that we gave training to care for people with spinal injuries because back then we were working with Canadian doctors. So they would come, bring in some things to help on the ward, catheters, dressing materials for the wounds after surgery, so many things. I was shocked when that particular nurse was selling the catheters to patients in the ward. Yes, it is happening in Mulago. Yet these are our friends that donated these things, but the lady was selling them to the patients on the ward. During my second stay there, that is to remove the metal plates, there was a particular person who was dumped by the relatives. And when they dropped him there, they abandoned him and left. So the nurse was mobilizing us to buy food for this patient. That is how bad our services are. In a normal setting, at least the hospital should offer at least a meal a day, but this person would go without a meal, lunch and supper, not even a cup of tea from the medical personnel. So that is how to show you our medical care is really bad. Putting that aside, to emphasize on the sign language, last year in October, November, I did a survey on private practitioners. I was dealing on accessibility to information and accessibility to the medical centers themselves. Shocking enough, around Mulago Hospital, because we are operating in Kawempe division, near Mulago, there were 6 of them, and none of them had a ramp. And the excuse they would give, the building is old, the building is not mine, KCC has refused me to put a ramp, a lot of excuses. If KCC has refused you to put a ramp, put a wooden one that you can move. I'm sure they won't beat you up for that. But all these were the funny excuses that were being given. And then even their washrooms were not accessible. You have to go downstairs, the entrances are small, so it's really a whole big, inconvenience when you go to these medical facilities. And then some of them really had attitude. I remember at one particular one I went, and the entrance to his office, the doctor, was so small and there were stairs. And even when he came out to talk to me, he was still on his phone. I could not enter the clinic because there was a long chair on the road, on the pathway. Even when he came out, he was still on his phone, not listening to what I have come to say. And I was wondering, okay, now, even if I had come for treatment, would I still, have the mind to tell this person how I feel? Because he's busy on his phone and he's talking to me. Then also, I'll emphasize free wheelchairs because it's our right. It's a need, not a luxury. At least government should have a budget of every 5 years minimum, because I see how long I use a particular wheelchair. It can do well for 5 years. But if our roads were good, it could even do well up to 10 years, because it's a matter of, servicing it like you service a car. But because the roads are bad, they're always breaking down and they're expensive. Yesterday I was doing a survey on the prices of wheelchairs. You cannot believe it, one wheelchair goes for 700,000. How many of those Ugandans in Nakapiripiti can afford a wheelchair? First of all, it's their fault the roads are bad. Two, they're taxing the people bringing in the wheelchairs, so they make the wheelchairs expensive. And for us, it's a need. And then we have a challenge of those people offering us free wheelchairs. They bring the bad type, they offer us the wrong size, they cripple us the more. Because if you get a child who is 10 and you give him a wheelchair of a person who is 20, 30, in a period of 5 years, they'll have scoliosis. You are disabling them the more. So are you helping or you're making the situation worse? And then we're also doing a survey on access to family planning.
Okay, Myleen, the network has interrupted. We shall get back to you. Ivan?
Yes, hello.
Can you hear me? Yes, I want you to rate Uganda's access to health. You should rate how much Uganda has achieved in guaranteeing access to healthcare by persons living with disabilities. In your view, and as a social worker, you can also give us quite some context in that.
Okay, thank you so much, members. But before I speak any word, allow me to apologize for the network problem, actually. That's why you are seeing me on off. And sometimes I'm even not getting well the words. Okay. Actually, it has not been easy for people living with disabilities to access health services. And I have some of the few challenges. And one of the challenges is lack of accessibility or accessible equipment. And those accessible equipments are like, actually, I want to thank the government because some hospitals, they are now acoustic. They have not, it's still a struggle because the way they constructed those hospitals, as if they didn't even think about a person with a disability, let me say to the reception, a very big challenge, meaning they just want us to access.
Ivan, we are having challenges hearing you. In the alternative, you can switch your video off and we hear you.
Okay, thank
Proceed.
you. Now, okay, thank you. There is now, again, a challenge to the blind people. Actually, those ones, it is very, 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 very hard for them to access health services. Otherwise, if they have either a white cane or a helper, there it can be somehow easier. But if someone is just like that, it is very, 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 very difficult. And there is also a challenge of low self-esteem. We people with disabilities, some of us, we have low self-esteem, which is sometimes leading us not to access health services. And another challenge is having fear to engage ourselves with the people who don't like us. For sure, some people, they don't like us. Like I had a school which had an Albinism. So when other children, they fear to see. So again, is also another challenge of health workers towards people with disabilities. Some people, they hate us for nothing. Like there was a time a lame girl was going to give birth. So by the time that girl entered in a labor room, nurses, these nurses and the health assistants, they're like, now imagine a person like you, also you want to produce a child. And they were asking that girl so many words like, who impregnated you? Why do you allow him? What? So those people, as if they never wanted to give help to that girl, which was very bad. Actually, okay, thank you.
Yes, thank you very much, Ivan, for that perspective. It's very important. I want to read out some statistics from the Ministry of, this paper was given to the Ministry of Finance. It was named Access to Health Care Services, Experience to Persons Living with Disabilities in Eastern and Northern Uganda. It was a briefing paper. And of course, it was noted that nationally, we have about roughly 5 million persons living with disabilities, and 1.3 are from Eastern Uganda and 1 million are from Northern Uganda. This represents almost half of the population of persons living with disabilities. And a number of things were reported. Key among them is discrimination. And in 2017, there was a survey, Uganda Functional Difficulties Surveys established that 9% of persons living with disability felt disrespected or humiliated by treatment and behavior of staff and health facilities. Essentially what Ivan has been talking about. 7% females, of these were females, and were mistreated. And among the other issues that inhibit access to health of persons living with disabilities is lack of appropriate, of course, discrimination. That is very key. I think it's the number one cause of discrimination. And then lack of appropriate equipment and assistive devices. Like all of you have said, we don't have equipment, few equipment, and those ones that are there are inadequate when it comes to addressing the needs of persons living with disability. And this survey noted that there is increase in access of adequate equipment and assistive devices. The district procurement officers in different districts in Eastern and Northern Uganda demonstrated limited skills for inclusion of equity concerns in all procurement procedures. For example, beds, weighing scales in hospitals, delivery beds, assistive devices, name it. There's a story, many stories of babies who are living with disability, or young people who these weighing scales do not cater. Many of these weighing scales require just standing, and then someone stands, even for adults, and they do not provide for those where persons living with physical impairments, physical disabilities, may not be able to stand, not be able to fully utilize those equipment. And of course, we've talked about not having braille, not having hearing assistive devices in hearing, not having people who help in sign languages, etc. So that was a big issue. There was also another inappropriate means of communication. And these are information where persons with disability can use to get information. There's in access to Braille, for example, easy to read formats, sign languages, all that. There is still a hindrance there, and little has been done. Now, this is a real government report that highlights the gap. So people with visual impairment also did not receive prescriptive brailles to enable them understand medical requirements. Of course, hearing, we have mentioned this before. Few hospitals really have persons skilled in having in sign language, name it. There is also lack of appropriate medicine. So patients who have, it was reported that patients who have conditions that could not easily be addressed using the tracer medicine, I think Prima can know what that means, were not served. Those having nervous system sicknesses like nodding syndrome, epilepsy, mental illness, and albinism. It was established that health facilities had a window to order for all other medicines outside the tracer. They did not order for such supplies. Now, this is Ministry of Finance noting this. So no health facilities prioritize supplies like sunscreen for persons living with persons living with albinism. Yet this is a very crucial matter for them. I and Ivan can help us understand whether there are access to many of these creams in different public health facilities. And on another hand, the medicine for mental health registered high stock outs. Imagine a stock out of 85% stock out. That is literally nothing remaining to treat persons with disability. So those are some of the key things that the Ministry of Finance noted in their survey. Lack of appropriate medicine, discrimination, inappropriate information, and lack of appropriate equipment. So I want to come back to you, or we've been joined, I want to come back to you, Prima, but before that, we've been joined by Andrew Kigai. Andrew, please introduce yourself, and then we shall proceed with Prima, and we shall ask the essential questions of what, I understand Prima, you have to jump off the call, but we shall ask, what do we need to do better to ensure that there is access and adequate access to health facilities? And it is notable that access should also follow other, it is in tandem with other necessities such as adequate, once we access, that accessibility or that health service should be adequate. Yeah. And then should there be a decision, that decision should be fully informed, an informed decision or an informed choice to deal with any matters pertaining to the health of persons living with disability. So you will help us understand whether indeed, what indeed we can do, what you health professionals can do to better the conditions, the health conditions of persons living with disabilities. You've had the experiences, you've also had the report. That was the briefing paper that was presented to the Ministry of Finance. Kigai, Andrew, please introduce yourself.
Yes, please. Sorry for the network was breaking down. My name is Kigai. I'm practicing the government facility. I'd like to join. Well, as to join, I met at presentations that have been made by the journalists, especially those presented by Myleen. I don't know, should I begin something from there? Should I begin my submissions from there?
Yes, please do. Go ahead and submit.
Vice President, thank you. We're looking at some of the challenges that may hinder the better access of those with disability people, or people living with disabilities, I look at this. One of them infrastructure, human resource, and I think talk about infrastructure, look back the communities where these people live. I realize that those in the communities, especially with the physical disabilities, for instance, those who are they're not even able to work, and most of them are poverty-stricken people, so not able to afford the equipments that have been talked about, like the wheelchairs, those are blind with the waiting, not able to afford them. And this takes back to if the government put a policy in place that to recognize those specifically in the various communities, and then maybe give a hand in availing those equipments like wheelchairs are required. And number two, also maybe in the road accessibility, like from the communities to access where these facilities are, it becomes difficult because most road networks are broken down. So they struggle, and because they struggle, they're not able to access the health facilities in time. Those are some of the hindrances and the challenges. So we request the government policy maybe if they will improve specific structural road network and the rest, like for instance, if they identify the spot identification where specifically these people live within specific communities, and then they will put a policy of improving on transport infrastructure network. Then number two, we come to construction position of our facilities. I want to report that of late there's been a bit of improvement compared by then, because most of the new architecture plans of building new centers, they give provision in consideration of those who are handicapped and of late. But those that were put many years ago, you find still the accent, they still have a bigger challenge. Still, it was a bigger challenge for them. And when you get into the facility, it comes to human resource point of view. Most of the health facilities, they have not been equipped with human resources, the people who are trained, for instance, sign language, for those who are dumb and maybe deaf. So when they come, we're not training them. We don't know what to do because there's nobody who is training to that who can help. So the patient to health worker ratio or relationship, it is hindered because you can't provide the best need of this patient. You can't listen to them, and neither can they also listen to you. So we recommend maybe in the community process recruitment, maybe at every health center 3 level and then hospital level, if they do employ and for that people who are trained in these sign languages. Specifically health center 3, because these center 3 levels are community based and are near the people in the communities. And it's where most of these people get their health services. So the government policy would consider this in the recruitment plan. That is every center 3 level, they can recruit somebody trained in the sign languages, maybe at the level of the hospital, because that make referrals to the hospitals always specifically. And that can also still help in enabling people to access the healthy services. I even was submitting, I think somebody even saw about the discrimination and the bad attitude of the health workers towards the people who come with disabilities. It's a point on ground. It's a point that I think we need to have programs, maybe to all the health service providers, that we let them understand that disability is not a curse, or it's not something, a liability to somebody's health. Everybody has a right, regardless of your physical shape, of your mental shape, but you have the right to accessibility to all the health services and have the right to be treated with dignity and respect because you deserve it. But of course, people are passing to problems that those within themselves will feel, I think so and so doesn't deserve. But as we go, maybe reach and sensitize them, those talk to them, sensitize them, then maybe they will continue the attitude, and therefore they can be able to provide and treat them as normal and as equal to all other people. As that stigmatization also with the people living with disabilities. they feel, I think they have or not normal beings. And even if you want to bring them on board, sometimes they do not qualify. So I think on this hearing, if we take it upon and we carry on the point of sensitization and a capacity building in them, they get to understand themselves and appreciate who they are and believe they are fully normal human beings and a beautiful life. If they can stand believing themselves as their potential, I think can go a bigger mile and allow them to access that health services. I think for now, most members have shared things. I'll beg to submit a mind from there. Thanks so much for listening to me.
Yes, thank you very much. And indeed, now we are in that area of making recommendations and suggesting what can be done. Prima, please, can you admit and also add on your suggestions on what you can do better to improve access to health of persons living with disabilities?
Thank you so much, Alex. I think that improving health access for people living with disabilities should be a multidisciplinary thing. Number one, at stakeholder level. Number two, at healthcare workers level. Number three, community level. And then we come to the people themselves. Yeah, the people living with the disabilities. I'll start with the stakeholder level. At stakeholder level, the facilities that we are talking about without ramp access areas, we are complaining about infrastructure, we are complaining about training of healthcare workers. I feel like at our level right now, we do not really have a lot we can change other than engaging the stakeholders. Because much as I, a health worker, would want to be able to communicate with my patient who cannot talk. Medical training did not give me sign language. So if I would want to do it, it would be on a personal basis, but I am not going to be in all the hospitals. So just like Dr. Andrew had talked about, I think if these healthcare workers are trained and distributed to the different facilities within the country, when these patients come in, they have people to go to. It would be a good thing. I would also like to acknowledge the point that Myleen noted, that people in Lacho are getting better care than people in Mulago. And she also mentioned that it has a missionary background in it. So we are seeing that all these facilities that we have an NGO or a partnership kind of it into, you know, our government partnering with these people. I would recommend that we have our stakeholders bringing more partners on board so that we are able to access such facilities that are specialized. The other point that I would like to note is about receiving aids, walking aids, hearing aids, and all these things. Yes, the NGOs are trying to give us something, but also I think our government should come in and do what they can. We generally have limited resources in the health sector. So I think that's why I was able to give a higher score than anyone else, because I know the conditions here are generally for everyone. The things are not available, catheters are not available, cannulas are not available, not just for people living with disabilities, but generally. So I think maybe if the stakeholders came up and gave sort of like a specialized care to these people, you know, when they bring in the equipment, they're like, no, this is for the people living with disabilities unit. Yes, I think it would be a good thing. I'll go on to the healthcare workers level. On behalf of all the healthcare workers, I would like to apologize for the scenario that Ivan gave when a mother came to deliver and the nurses were saying all this and that. I apologize on all the healthcare workers in this country, and I just hope that if any healthcare worker watches this video, they never do such a thing, because a hospital is a place where people are supposed to come to find comfort. They come in pain, they come for help. So we can't make them feel more helpless again. So it's very unfortunate. To the fellow healthcare workers, I advocate for attitude change. People did not choose to live like this. Some acquired it along the way, meaning it can occur to anyone, it can occur to you, it can occur to your relative, to your child. So it's really very unfortunate that we are saying all these things, all these shameless things to patients who come to us for care, for comfort. I advocate for attitude change for the healthcare workers. Much as we are frustrated, I understand. I talk to some healthcare workers and they're like, I'm also frustrated. There are no cannulas, there are no catheters. How am I supposed to work? It's not the patient's fault. It's not. We can't offload our anger on the patients. Yeah. So attitude change. I come to the community, down to the community level. These people need support most of the time. I have worked on a ward, a children's ward, where children have neurological disabilities. For example, those children who cannot walk, you've seen those children who cannot talk, the children who have hydrocephalus, those are the very big heads, and they have developmental delays. So first of all, these parents come to you when they are frustrated. These children are always in and out of hospital. They don't go to school because of their condition. They always need care. They can't do anything on their own. They need help to go to the toilet. So by the time the child turns 13 years, the parents are very frustrated. Now, this brings me to the community. A colleague still was telling me about a scenario where there was a patient with a disability. I think he was lame, and he was in hospital, but he needed help every time he would be going to the toilet to ease himself. So you find that he would need help of the caretaker. It was a brother or someone. So in fear of telling the brother every now and then, please take me to the toilet, take me to the toilet. This patient minimized their feeding habits. Yeah, they were scared of eating. So imagine we are giving drugs and we are telling you, please eat, but then you cannot eat because you're scared of going to the toilet. Yeah. So we appeal to the community to be kind to these people. If you're walking on the road and you find this person that maybe they need help with pushing the wheelchair, I know you're rushing, but extend love, This is how we're going to improve how they themselves feel about themselves and how they feel about the people around them. Ivan was telling us that they feel like people around them don't like them. So I feel like if we as the community become more empathetic, would make these people feel better and hence improve their health-seeking behaviors, because they're going to feel like, oh, I don't feel well, I need to go to the hospital, but because they know they need to first convince their brother or their cousin to push them to the hospital, they can't go on their own. They're going to stay home, and this condition is going to complicate just because they couldn't come to hospital because the community is not supporting them to push them to the hospital. I come down to self, to the people living with the disabilities. The main challenge that we are having here was self-esteem. Now here, I commend support groups. Reason why I am in the hospital setting most of the time, and I see patients with different conditions. So you find that a patient comes to you maybe from the triage area or casualty where there is everyone with every condition, and then they are very worried about their condition. You know, they feel like their condition is the worst condition. So they ask you, so have you ever treated anyone with this same condition? Did they get better? After some time, because after triage, Mulago being a super specialized hospital, we transfer them to their specialized wards, the wards where people with that same condition are. So they reach there and they change, like their attitude. They become brighter because they are seeing people with the same conditions who are getting better. They see people who are being discharged and going home. Things that make them feel better about themselves are not really big things. Some people pick contacts from the ward of people having this same condition. I think I was on a ward where of children who were born with exposed intestines, and these children have a very long stay on the ward, and that they need, follow-up plan. They keep coming to the hospital. So by the time these patients would leave hospital, they had each other's contacts, they were friends. So support groups are a very big thing about how you feel about your self-esteem. Well, I am not in this alone, much as other people are looking at me this way, but well, we are 5 of us in this district and we are surviving, and the other has gone to school and finished their education and they've gotten this job. You can clearly see the light at the end of the tunnel when you're not in this alone. And we also promise to change our attitudes as a community, as the healthcare workers, because also this will help on boosting the esteem. Kindly come to the hospital when anything is wrong. We at personal levels will try to see what we can do. And I think the stakeholders also will heed to this message and see what they can do. Thank you very much.
Thank you very much for that. And yes, to Myleen, what would you want to see change?
Thank you so much, Dr. Prima, and all the other presenters. I'm really happy to be part of this discussion. 3 major areas where I would love to see change. For those who are still under training, the medical practitioners who are still under training, I would recommend that they are given at least 3 months of sign language lessons before they leave. And then maybe when they're out in the field practicing, they are done like a review. 6 months after they are enrolled out, they are done a review to see how best they are communicating, and maybe to challenge them or hold a session where you're using sign language to see if they have mastered the language and they can communicate easily. Yes, and then also in the hospitals where the young medical practitioners, can we pass on the services? It's a matter of gathering a few from this region, a few from this region, and training them in a particular place. And then we'll get rolled on sharing information and solving the problem of lack of communication. And then also it's a very simple thing, though very expensive, to use Braille for those who have a visual impairment. Basically, let's pass on the information as government. Please do Braille information. There are students who know how to do these things. It may not be so, you may not need a specialist to do this thing. Give the information to them, especially children from the Uganda School for the Deaf, Mbale, and so many other schools. if someone reads to them that information, they can braille it for you. It will be cheaper and easier for us to, at a minimum cost, of course, to support them, to roll out this information, health information on anything, for preventive methods, treatments available, and causes of those sicknesses or ailments. If we have that information in braille, that our colleagues with visual impairment can access that information and do the needful. 2, insurance. As Parliament was discussing about insurance, how far are we on that? I know not all of us may afford to participate, but it would help if one of my rich relatives has this insurance and I need care and they refer me to use that insurance. Surely it can solve something because I'm part of their family. Then 3, can we have surprise inspections of clinics, hospitals, because some are still dirty. The standards are alarming. And then also, before licenses are given to private practitioners, can a person from KCCA or government at any level inspect the places where they're going to operate so that we can have minimal accessibility? Even if the building is old, it doesn't require a lot of money to make the small adjustments needed, so that we give people a license to operate the right way. Every time we just issue licenses, we are encouraging them to ignore some of the most important things like accessibility before anything else. Then lastly, there's an organization for people who have speech impairment. If government would partner with those, they could be able to offer a package to train nurses and other medical practitioners on basic sign language. It's something that you have to learn and practice. If you learn and you don't, then you forget. So at least if from a hospital are given and others can learn from. Just a matter of empathy. If the nurses and the doctors to look for sign language, it's all over social media. Just use and doing the small steps, and we can make this work. Then lastly, can Uganda medical stores join MS, Ministry of Health, or no tax on basic assistive devices? I'm talking about walking aids, I'm talking about hearing aids, I'm talking about wheelchairs, I'm talking about catheters. Because for people with spinal injuries, there's some that cannot do without catheters. And if they're expensive, then the minority upcountry cannot afford, and yet they need this to survive if they're going to fit in. We have issues of urine incontinence. So even if you have built my capacity, I've gone to school and I have this problem, I'll not come out, because who wants to be in a place where you're smelling for people? So some of these things, we just need taxes removed or reduced so that they are affordable to us as people who have these challenges. I want to end there and thank you everyone for your efforts, for the passion to do what you're doing and to make a difference. Actually, one of the things that keep me going is when I meet someone at their lowest and I inspire them and see them get somewhere. To me, that is worth living. Even if I'm not paid money for anything, that just encourages me to keep doing what I'm doing. So out there, whoever you are, whichever position you hold, please, your office, use your influence to make changes that will make the future better for those coming after us. Thank you. I submit.
Okay. Colleagues, friends, we have reached the end of this show where we have proposed a number of things that we do. Okay. There are some of the policy considerations that were suggested, but of course, all these you have stated, and they indeed reaffirm what was stated by the, what was recommended by the Ministry of Finance, which they adopted from a policy brief that I've been reading to you. They said the policy recommendations were the Ministry of Health should adopt holistic planning in their next health sector development plan and NDP3, which I think we entered already, to ensure universal access to health services. Ministry of Health and National Medical Stores should expand tracer medicines to include those that address special conditions for persons living with disabilities. The Ministry of Health should provide training to health workers in basic sign language interpretation and other key skills to ease access to services. In addition, staff ethical conduct should be strictly enforced. Yes, and I think those are good recommendations. And as a lawyer, I would also add that we should, all our laws that have criminalization of disability should be repealed and done away with. We still have, Ivan, are you able to?
Yes, I am having here only one word. Please let the sunscreen lotions so that people with the albinism also can at least maintain their skin. We as EFPA, we are trying to distribute some of those lotions, but also we are just getting them from our sister organ. So they give some people miss, and some of our friends actually are dying of skin cancer. Now, at least let the government of Uganda, I think, about us also. Thank you so much, Mr. Martin.
Thank you very much, and we are sorry that the network has made it a bit hard for you to contribute wholesomely, but we thank you for those inputs. So we still have legislation, we still have laws that criminalize living with disability. If they do not, there are still laws that inhibit access to health when it comes to persons living with disabilities. And some of those laws are the Mental Health Act. The Mental Health Act still has provisions that are dangerous for keeping persons living with disabilities, with mental disabilities in prisons. Prisons should not be places where people with disabilities, particularly mental disabilities, are kept. No, they should be kept in places that will fully offer them adequate health care, that will fully give them adequate rehabilitation and all the needed professional support, but not prisons. We still have reference to derogatory terms that are being used. Yes, much as many of these have been declared unconstitutional by the Constitutional Court, but we still have laws that refer to people as idiots, that refer to people as imbeciles, that refer to people in all derogatory terms. They should be done away with. We still have language in a lot of literature that refers to people as invalids, and all those other derogatory terms. If we do not remove this, they also have a very negative repercussion on access to health, because as you've heard, people do not even consider persons living with disability worthy enough to access health services, to also have sexual and reproductive health priorities. So there should be serious reform on part of government to decriminalize stigma, to decriminalize living with disability, still as if a crime for a person to have a disability, yet it is not. So all those words that are couched in very derogatory terms should be done away with. Prohibitive language should be done away with. Discriminatory language should be done away with, and discriminative laws, but also the real question of finances and appropriating finances to the needs, to the health needs of persons living with disabilities. It is unfortunate that this modern day and age, we still have laws that further put persons with disabilities at the fringes of society. The Parliament continues to make bills that still view persons with disabilities as incapable of giving consent, and such are regressive in terms of access to health services. There are very many more recommendations, and you have given the best recommendations. We hope these are prioritized. We hope there is more this information dissemination that handles all our different abilities and inabilities, including people who do not have visual, who are not able to see and they have visual impairments, people who also have hearing impairments, people who have speech, impairments, name it, should be also allowed to access information. And among that access to information also includes the freedom to ask and be responded to. I pray that all of us see the urgent need to respect each other, see the urgent need to ensure that our brothers, our sisters, and all persons that are living with disability need to access health services adequately and very urgently for those who need it at that particular time. That this, in essence, also benefits us. It also makes the world a better place. I thank you, Andrew. I thank you, Prima. I thank you, Myleen, and I thank you, Ivan, for being a part of this discussion. It's these discussions that will further shape our society and make it better. I thank you and wish you a great week.